I will be presenting talk of Dr. Terry Mamunas about refining axillary management after neoadjuvant chemotherapy. What does the evidence support? Next slide. So basically, this slide is going to be about how safely the axillary lymph node dissection can be minimized in breast cancers. So as we all know that so for a longest time in early breast stage cancers, axillary lymph node dissection was supposed to be an undisputed standard of care. But after NSA-BP B04 trial showed that there is no overall survival benefit, and after that its therapeutic role was challenged. Next slide. Next slide. But still, there is still rationale for axillary lymph node dissection in early stage breast cancer, considering it still provides a good local control in axilla. It provides a good staging information, and it assists us to get an optimal adjuvant systemic therapy plan. But if you watch closely, the most of all these things can be achieved through sentinel lymph node biopsy also. So and at the same time, while it provides us the good information on these topics, at the same time with considerably less morbidity, about which Dr. Shagun has already warned us in last presentation. Next slide. So can we really decrease the extent of axillary surgery with NSAT in all cases? So right now, as far as the evidence is concerned, feasibility and accuracy of sentinel lymph node biopsy after NAC is still questionable in locally advanced breast cancer. But yes, this concept can be is acceptable in operable and early breast cancers, which is CT3, CT1 to CT3, and clinically node negative to N1 diseases. Next slide. So in this presentation, the flow chart is basically going to be in early breast cancers. Is it feasible to do sentinel lymph node biopsy? Is it feasible and safe to do sentinel lymph node biopsy after NACT in node negative and N1 diseases? Is it safe to omit axillary lymph node dissection in case of all PATH-CR patients who have received NACT? And how to decrease the false negative rates post NACT? And is it safe and can we achieve good local control? And is really the morbidity with sentinel lymph node biopsy is lesser? Next slide. Next slide. So as we all know that post NACT, almost in 30 to 40% cases, the axillary nodal staging is downstage. Next slide. And next slide. And with the extent of better and better chemotherapeutic agents and with better knowledge of tumor biology, we are getting more and more PATH-CR rates, and this is what we want to bank on while considering NACT. And we try to minimize the axillary nodal dissection in early breast cancers. Next case. Next slide. So, but there is still some theoretical concern over applying the sentinel lymph node biopsy concept to patients who have received NACT. There is one anatomical concern that post NACT there might be some alternation in the drainage pathways, and there is a biological concern also that post NACT sometimes the tumor in the sentinel lymph node might regress, but there might be some disease which is left in non-sentinel lymph node. So in either of these situations, there will be a high risk of high sentinel lymph node biopsy false negative rates. So this is the big concern, that we should be sure that there is actually a PATH-CR in axilla when we are getting away with sentinel lymph node biopsy. Next slide. So why it is clinically important to be sure that the axilla is actually actually we have achieved pathologically CR in patients after NACT, because as we know that if you just rely clinical palpation in NACBP B18 trial, we had witnessed that even if the axilla was clinically negative, almost 40-50% patients were node positive when the surgery was done initially, and even after NACT, at least 30% patients were turned out to be a node positive one. So we should be really sure that what we are dealing with. Next slide. So the guidelines do recommend that even if the axilla is clinically, you feel that it's a node negative axilla, the ultrasound of axilla should be done, and it should be augmented with FNAC for the indeterminate node to know its status, and it can be marked in the same setting which will help us for further nodal removal. And it provides us a good sensitivity and specificity. Next slide. So how we manage the patient with clinically who are CN0, that is node negative axilla, and we are planning to start them with NSCT. So should we do sentinel lymph node biopsy in early breast cancer, node negative breast before starting chemotherapy, or it can be done after NSCT while we address the breast also. So this question is very important because if we cannot trust that after NSCT the axilla can be addressed, we have to subject patient for surgery twice. But so next slide. But we have a next slide, please. But we have a meta-analysis which says that sentinel lymph node biopsy, if done even after NSCT, has a very low false negative rate, which is somewhere around 6%. And the pooled identification rate for sentinel lymph node biopsy even after NSCT in such patients are almost 96%. So it concludes that sentinel lymph node biopsy is technically feasible, accurate for axillary staging in initially clinical node negative breast cancer patient even after NSCT. Next slide. So what about patients who have clinically hello. So there is another meta-analysis for sentinel lymph node biopsy after NSCT in patients with documented and involved axillary nodes. So the last slide was about the patients who have negative nodes. This slide is for patients who have axillary positive nodes. Here we can see that in this particular meta-analysis, what they found that the after axillary lymph node dissection, the false negative rates were quite high. That was somewhere 13%. And although the identification rate was good, but the conclusion of this meta-analysis was that sentinel lymph node biopsy after NSCT in a biopsy proven node positive patient results in reasonably acceptable false negative rate and identification rate. So it was making it a valid alternative to axillary lymph node dissection. But there was still a concern that we should improvise the false negative rate and identification rate in such subset of patients. Next slide. Next slide. So these are the four trials. These are the four trials in which the similar thing was done, and different things were tried to get the false negative rates to a lower level. The first trial was the 1071 trial, in which they used the dual tracer, and the false negative rate was somewhere around 12%. The Sentina trial, in which what they did was they used a technetium dye. It was only a single mapping, and the false negative rate was somewhere around 14.2%. SNF-NSC trial, they again used technetium plus they used the IHC to the sentinel nodes. So in this particular trial, in view of use of IHC, the false negative rate was much lesser than the other trial. It was only 8.4%. And the last Guinea 2 trial, again they used the dual tracer, and with which the false negative rate came down to 11.9%. Another finding which was common in all this trial was whenever the nodal yield was more than 2 lymph nodes, the false negative rate even went down. Like for in Z1071, it went down from 12.6 to 9.1%. In Sentina, it went down from 14.2 to 7.3% if it was more than 2 nodes. And same about in Genia 2 trial. It again went down from 11.9 to 7.8%. So the conclusion which was from this particular 4 studies was that if we are able to get better sentinel lymph node yield, the false negative rates will go down. Next. So there was again a reanalysis of G1071 trial, in which what they found was that at the time of axillary lymph node dissection, along with the axillary lymph node, if they were able to retrieve the clip also, or the clip node which was initially placed to identify the positive node, the false negative rate went down to 6.8%. So again, from this, they came up with a conclusion that whenever possible, mark the node and try to remove those clip node at the time of axillary dissection. Next slide. Next slide. There is again an MDACC experience in which again they did the same thing. They removed the sentinel lymph nodes also and clip lymph nodes also, and they labeled it as a targeted lymph node dissection, and with which they achieved the false negative rate of 1.4%. Next slide. So there are different methods which are tried in case of a node positive early breast cancer in order to increase the in order to decrease the false negative rate. In this particular trials, RISAS procedure was done, in which what they did, in the prior to NACT, they radioactive iodine iodine was instilled into seeds were instilled into the positive nodes, and they were retrieved at the time of axillary lymph node they were retrieved at the time of sentinel lymph node biopsy along with the sentinel lymph nodes. Next slide. And with this procedure, they were able to get the false negative rate to a 3.47%, and the negative predictive value with this procedure was more than 93%. Next slide. Next slide. Okay. So the systemic review and the pooled analysis gives that if you do a marked lymph node biopsy alone, the false negative rate is somewhere around 6.28%. And if you do a targeted axillary dissection in which you remove both the marked or clipped nodes along with the sentinel lymph node, it goes down to 5.16%. Next slide. So these are the different markers which are commercially available for the marking, and as per the particular institute's guidelines and use, they are getting deployed. That can be steel, titanium, polyglycolic acid, carbon or black ink tattoon, or radioactive iodine, or ferromagnetic seeds. Next slide. So these are again newer method: radioactive iodine, Savi, Scout, magnetic seeds, which can also be used. Next slide. So I'm coming to almost a conclusion now. So the most important thing for optimizing sentinel lymph node biopsy performance after NACT in documented node positive patient is first appropriate node selection. It is currently applicable only for early breast cancer. Whenever possible, do a dual agent mapping, isotope plus blue dye. Whenever possible, identify and move more than 2 sentinel lymph node. If possible, if a clip placement is done, it should be localized and retrieved. That is what we call as targeted axillary dissection. Consider performing immunohistochemistry staining on sentinel lymph nodes so that we can get the lesser false negative rates. Next slide. So now,
Sagar, kindly conclude, please.
Yes, sir. Last 2 slides. So about the axillary recurrence rate with negative sentinel lymph node biopsy alone after NACT, you can see the axillary recurrence rates are almost in a single digit. So it's a relatively safe procedure. Next slide. Then another concern was if there are only micromets in sentinel lymph nodes. In that particular case, if only sentinel lymph node biopsy is enough, or we need to do an axillary lymph node dissection. So as far as the MSKCC experience is, they do recommend that even in the case of micromets, you should go ahead and do the axillary lymph node dissection. Next slide. Next slide. So this is what this trial might help us to get a knowledge that in case of node positive patient, if node positive patient, if after NACT, if axillary lymph node biopsy is positive, in that particular patient, instead of axillary lymph node dissection, can we get away with radiotherapy? But the results will tell us about it. Next slide. Next slide. So this is the summary what we have already talked. So NACT helps us to sterilize the axilla, and we should always mark the suspicious nodes before NACT. In N0 patient, sentinel lymph node biopsy after NACT is acceptable. Whenever possible, in case of a node positive early breast cancers, before after NACT for sentinel lymph node biopsy, always try to retrieve more than 2 sentinel lymph nodes. Use dual agent mapping and use IHC. Next slide. And it will help us to reduce the removal of marked lymph node will help us to reduce the false negative rates, and the necessary of completion of axillary lymph node dissection in node positive patients is still there. And can we get away with radiotherapy? That the future will tell. Next slide. Thank you.